Well, these are two very good drugs, both of them approved for this indication of patients who have received 2 or more tyrosine kinase inhibitors or who have the T359 mutation. And we've seen recently studies looking at different aspects of both of them. Ponatinib has been there for a long time. Now with this response-directed dose reduction, we've seen much less issues with arteriocclusive events and very high levels of efficacy. With Asciminib, recently approved a few months ago, we've seen also very high levels of response in a similar patient population. Also activity in a T359 patient population, although there you need much higher doses. I think the drugs are very, very good, both of them. There are some differences in some aspects of them. For example, although the schedule of the Ponatinib decreases significantly the risk of arteriocclusive events, it probably still has a higher risk than for example, Asciminib, although of course Asciminib we have shorter follow-up and we need to see what happens with longer follow-up because these events can continue to occur, but it appears to be perhaps safer. The schedule is a little more complicated, particularly for the T359 patients for Asciminib because it requires twice a day. It's a large number of pills and it requires fasting 2 hours prior, 1 hour after. We have a little bit more follow-up with Ponatinib. On the other hand, the Asciminib shows good activity even in patients who have received prior therapy with Ponatinib. The way I see them is that rather than having a blank statement of this drug is better than the other one or something like that, all of this information allows us to look at our patient and see, depending on their features, the risk of arteriocclusive events, their disease characteristics, their preferences for schedule, their adherence, and all these things, what may be the best option for one patient, and that may be very different than a different patient. I think overall, having more than one option that works very well in this setting is very important. After all, as good as the treatment is for frontline, we do have a number of patients that go through a second and a third and a fourth TKI, so we really need all of these options. I think what's important is to make sure that we understand the drugs well, that they understand the data well. None of these drugs should be avoided just blanket-wise or preferred for every patient, but rather go through all the characteristics and decide what's best for the patient that we're facing at that time.